So we start. On behalf of DKI, I would like to welcome all of you on this online platform. And I would like to thank DKI for connecting us through this platform, which has been there for a while. DKI has been operating uh, online forums, and they're trying their best to promote professional development education. And we are courtesy DKI, we are connected together. First of all, I would like to thank all of you to take your time off from your busy schedules um, and show your commitment towards learning more and more. I really appreciate, and I hope we will be together for the next 6 months. As you have already noticed that this is a little longer course, over 6 months, starting today. We will be requiring some kind of commitment from you and of course from my side. It's a weekly commitment for 1 hour. I hope it's not a big one. I know you guys are busy. So we will be asking, or I will be asking for 1 hour from your time, maybe 1 hour, 15 minutes each session every Saturday for next 6 months. The format of the course will be in English only. We will communicate, ask questions only in English. And each lecture will be, or each session, we'll call it a session. Each session will be 1 hour long with 15 minutes question answer session. We'll try to make it as interactive as possible. And then this is what my suggestion would be, that I would like to take a 5-minute break in between, let's say after 30 minutes, so that your time spent for attention is okay, so that you can continue to concentrate. If you go all together over 1 hour, it might you might lose your concentration, or your attention span could be a little bit shorter. So we will try to take a break after 30 minutes for 2-3 minutes, or maybe maximum 5 minutes, and we'll restart. So each session will be 1 hour and with 15 minutes question answer. So please, my request would be that when you ask the questions, keep the questions pertinent to the relevant topic that was discussed in the current session. You have to be patient. You may have questions which we may be answering later on. So be patient. Just stick to the topic that we will discuss on a particular session, and keep your questions focused to that session only. Again, I would expect all of you to be regular, which means that you will not have any off days from the sessions. I know you people are busy. The holidays are coming. You people might be traveling, but then it's an online course, so all sessions will be live sessions online, so you can easily join from wherever you are. So regularity is the key. Each session that we do is connected to the next session. So if you miss a session or two, you will be at lost when you attend the next oncoming sessions. So please be regular. And the punctuality is very, very important. We'll try to stick to the time. 1 hour would mean 1 hour. We'll start sharp 1 o'clock, 1 p.m. Eastern Standard Time, USA. Now, the session can be repeated occasionally. This is not a regular feature of this course, but if more than 50% of the participants will request, I would repeat the session, and we can decide a particular date when we'll repeat it, or we can use one of the Saturdays to repeat it. But that's not a regular practice, of course. That will be upon request of more than 50% of you. We will go a little bit slow in the beginning and build up our pace. Remember, it's a marathon. It's not a sprint. We are together for next 6 months. We'll act like a family. And I will make sure that even though we start a little slow, we'll pick up the pace and try to finish the course in 6 months. If we cannot finish the course in 6 months, then we can continue for another few sessions if need be. But make sure that the rest assured, the course will be finished. Now, when you are attending the sessions, I would like to highlight one thing that some of you, you're practicing at different levels. Some of you are trainees, some of you are already practicing. So please be patient when you attend the sessions. So let's say if I'm presenting something and you already have a good idea about the topic, the others may not. And even within that topic, you may know few things and you may not know all the things. So when you're attending the sessions, try to take some take home messages from that session and just continue to attend the course and be patient. Uh, I plan to make a WhatsApp group with all of you who will be registered with the course after today's session. We'll finalize the list of registered participants, and I'll make a group with all of you. We have your WhatsApp number. If we don't, then I will request you to share with DKI. And the purpose of that group will be that over next 6 months, we'll be in touch with each other, even between two sessions. And that in touch would enable us to share our thoughts. I would welcome your feedback. At the same time, you can ask some questions if you have not asked in the previous session. And those questions will be addressed in the next session. And I think the question answer sessions are very important because if one of you will ask a question and others may not be able to, frame that question in that particular way, so the others will get the benefit. So the ones who are asking questions, the answer will hopefully benefit more candidates or more participants. So with this, I would like to start our journey, which is about neonatal and pediatric mechanical ventilation. Okay, I would like to just overview the content of the course. You may have already seen in the course page on the website, the curriculum. I'll just very quickly browse through the content of the course. We'll start with the introduction to mechanical ventilation, uh, then go into the pulmonary anatomy and see the differences between pediatric group, neonatal group, and adults. And then we'll move on to pulmonary physiology, which is a good chunk of this course, because I believe that without understanding or without having a sound or deep understanding of pulmonary physiology, you cannot safely and effectively practice neonatal ventilation. Uh, so we'll learn about lung volumes and capacities, total lung ventilation. Then we'll go to dead space ventilation, alveolar ventilation, then mechanics of breathing, compliance, elastance, airway resistance, work of breathing, time constant. Then this is very important, alveolar gas equation to learn about the gas exchange, then ventilation perfusion relationship, then transport of gases, then monitoring of gases, and finally, we'll end the physiology sessions with control of respiration. Then we'll move on to mechanical ventilation, uh, conventional ventilation. We'll see the phases of mechanical breath. And based on that, we will learn about the nomenclature of different ventilatory modes. Then all those modes, we will review them. Uh, then a very important subject, patient ventricular asynchrony. Then we'll go to NAVA mode of ventilation, high frequency ventilation. Then finally, liberation from ventilator, how to extubate and what are the uh, criteria that we use to extubate and how effectively we can extubate the babies so that we don't re-intubate them. Then we'll move on to non-invasive ventilation, which will include, of course, CPAP and high flow invasive therapy. Then we'll go on to pulmonary graphics, learn about acid-base balance, and then finally, our course will end with blood gas analysis. I'll share with you multiple clinical scenarios and how to analyze blood gases based on what we learn about acid-base balance. So this will be our content of the course over next 6 months. I will start with this slide that mechanical ventilation is basically a combination of science and art. And if you combine them together, it can bring wonders. Now, we will be learning over next 6 months the science of mechanical ventilation, and which is, of course, the bulk of it. Without the science, you cannot perform the art also. Art of the ventilation is uh, when you practice it, and the more you do it, the more you learn how to get a feedback from the patient, and it's all about experience. So that you will develop at the bedside. The more you practice, the more you will be better at practicing mechanical ventilation. But you should have a sound understanding of the science behind it. Yeah, okay. I get few messages from Dr. Mahnur. She says no, no, no voice, cannot hear sound, cannot hear you, from Dr. Taisir. So kindly please let me know if you can hear me. It's fine now. Now it's okay. Excellent. So one of the primary indication for mechanical ventilation is sudden respiratory or cardiac arrest. Then you have your impaired gas exchange, which you call respiratory failure. So try to identify the difference between respiratory failure and respiratory arrest. Overwhelming work of breathing, where you have the risk of diaphragmatic fatigue. You try to take over and help the diaphragm and the baby to ventilate and take the load off the diaphragm. Otherwise, the diaphragm fatigue will lead to cardiac arrest. Poor respiratory drive or frequent apneas. Surfactant administration is one indication which we used to do with ensure technique or otherwise, but now when we are practicing LISA or less invasive or least invasive surfactant administration, so we rarely intubate children for this reason. We can give surfactant without intubating them. Major airway or lung malformations, optimization of oxygen delivery in cardiogenic shock, even though directly there's no respiratory problem, but we have to maximize the delivery of the oxygen to the tissues, and at that point ventilation is very important. Safety during transport. Let's say a child who is being transported to a facility for cardiac surgery, for a child who has congenital heart disease, and he has been started on prostaglandin E1. One of the side effects of prostaglandin is apnea. So you would like to intubate them sometimes based on your judgment before you transfer them, because it is a nightmare to have a child with apnea during the transport, and you have to intubate such a child. That's a bad judgment on our part if we leave the child who has a risk of having apnea during the transport, especially if it's a long transport. So you should intubate the child and then move. And then preoperative, when they're getting anesthesia, they usually intubate for surgeries or any procedures. What are the goals of mechanical ventilation? When we intubate them, what are we trying to achieve? A goal is very simple, that achieve adequate lung volume for effective gas exchange. And I would like to highlight something here. We are not delivering the pressure. Our aim is to achieve the volume in the lungs. The pressure is something that the ventilator uses to give the volume. But our target is not the pressure. Our target is the volume. So we have to achieve an adequate volume in the lungs. Adequate means that we should not have more or less volume to avoid volume trauma. But the point here is that please do not think that the pressures are important. The volume is far, far more important than the pressure. Actually, there's no comparison between the two. If you see, we'll see in future slides that uh, the pressures are not even present when we do normal volume increment under spontaneous ventilation. Reduce work of breathing is another goal of mechanical ventilation. And the third one is very, very important, is to limit injury to the respiratory unit. And what do I mean by respiratory unit? The respiratory unit combines airways, alveoli, pulmonary capillaries, and respiratory muscles, especially the diaphragm. So all of these combine together to make respiratory unit. We have learned or we have heard about this terminology, villi, ventilator-induced lung injury. There's a new term being coined and discussed in the literature called ventricular-induced diaphragmatic dysfunction, or VID. I would like to call it ventilator-induced respiratory injury, or VIRI. Why respiratory? Because when we intubate children and put them on mechanical ventilation, whatever damage or injury comes through the artificial mechanical ventilation that we're using, it affects not only the lungs, not only the airway, it affects other parts of the respiratory system also. And we will see all along when we review a lot of different topics, in this course. So with this background, I would like to highlight the objective of my course. The main objective will be these two: when to use mechanical ventilation, and more importantly, when not to use it. But when you decide to use it, how to use it effectively, and then how to escape from the harms of the mechanical ventilation. And another important is when to stop using it. So when you start using it, this is what you should uh, practice and learn to do effective ventilation away from harms. And then every day you should think about, how can I stop the ventilator or extubate the child. Now, we will go through very briefly pressure changes during normal respiratory cycle. Just give me a minute. Okay. So if you see, this is a picture of a lung. There are three spaces or three compartments which are extremely important when we talk about pressure changes during the respiratory cycle. One is the atmosphere outside the body. The other are the alveoli, and the third is the pleural space. So this is the atmospheric pressure here, and then you have alveolar pressure, and then you have pleural pressure. Changes of pressure in these compartments will bring inspiration as well as expiration. So the atmosphere, it's the pressure in the atmosphere is called atmospheric pressure, which is about 760 millimeters of mercury at sea level, which for the reference purposes will be mentioned as 0. Then alveoli will have intraalveolar pressure, which is at FRC is 0, and we'll learn more about it later on. Then you have pleural space, so pressure inside is the intrapleural pressure, which is always negative during the respiratory cycle. During inspiration, expiration, at the end of inspiration, end of expiration, it will be negative, except for two conditions. One is the pneumothorax, where you have pleural pressure exceeding the alveolar pressure. So this is your pleural pressure. It exceeds the alveolar pressure, and the result is your lung collapse. So your pleural pressure becomes 0, which is positive, it is not negative. And then it compresses your lung because it becomes more than the alveolar pressure. The other condition that we have pleural pressure, which is positive, is the positive pressure ventilation when we are doing mechanical ventilation. In this case, the alveolar pressure is more than the pleural pressure, even though pleural pressure is positive, but alveolar pressure is more than the pleural pressure. And this alveolar pressure comes from the ventilator. And that's why the lung expands. So these are the only two conditions where your pleural pressure will become negative. Otherwise, it will become positive. Otherwise, it's negative during respiratory cycle. Now, pressure changes are important to move the air. They are created by the diaphragmatic activity and other respiratory muscles, mainly external intercostal muscles. But the main muscle of respiration is diaphragm. And this pressure change is called either delta P or driving pressure. That means P2 minus P1. So if you have a difference of pressure between two pressure compartments, only then the air will move. So when the diaphragm in this cartoon, the diaphragm, this one is contracted, And if you notice here, contracted diaphragm is more flatter, and the relaxed diaphragm is more dome shaped. So when the diaphragm contracts, it becomes flatter and increases the volume in the lungs or intrathoracic volume. And the decrease in the volume will cause lower pressure. And this lower pressure will be lesser than outside atmospheric pressure, and the air will move in. And the opposite will happen during expiration. So let's say we are learning about inspiration. Now, inspiration, the diaphragm and external intercostal muscles contract with ribs moving outward. What are the consequence? What is the consequence of this one? Intrathoracic volume increases. Pleural pressure becomes more negative. That means it drops. And then the consequence of this drop in pleural pressure is drop in the alveolar pressure. So if you see here, this is the atmospheric pressure 0. The pleural pressure becomes more negative, and because that means it drops further because of the increase in thoracic volume. And then it goes down to, it leads to lowering of the alveolar pressure also. Because the alveolar pressure is lower, so it becomes lesser than the atmospheric pressure, which creates a driving pressure, and then air moves into the lungs. When the air moves in, the tidal volume or the inspiratory volume is delivered. Then the next step would be that the alveolar pressure will start increasing, and then it again becomes 0, same as this one. So the air stops moving in, which is the phase of end inspiration. So I hope it's quite clear that this is how the inspiration uh, works under normal circumstances. These are all spontaneous breaths. If you see the graph, you can see this line at 0. Both the pressures, intrapulmonary and intrapleural. Intrapulmonary is basically PL, which is the alveolar pressure. Both of them become negative while the inspiration is taking place. What about expiration? Opposite, except that the expiration is a passive process when the diaphragm relaxes. There's elastic recoil forces, which will decrease the thoracic volume, which was already increased during inspiration. So now the thoracic volume will decrease because of this, and decrease in volume means the pressure will increase, which will lead to increased alveolar pressure. You can see it here, it's just the opposite. And then your alveolar pressure will be more than your atmospheric pressure. So the air will move in this direction. That will create your driving pressure. The air moves out of the lung, and the alveolar pressure starts to increase and returns to 0 again. Then airflow, when the the alveolar pressure becomes 0, there's no more air flowing at this stage, and then airflow stops, and then this is the end of expiration. And this is where the FRC is. So FRC basically is the volume in the lungs which is retained by the lung at the end of tidal expiration. I will repeat it. FRC, which is the functional residual capacity, is the volume in the lungs at the end of tidal expiration. And we will go through this FRC in coming sessions in more detail. So if you see the graph of this one, you can see the alveolar pressure becomes a little bit positive, relatively speaking, because it goes from -10 to -5, and the alveolar pressure becomes positive until it reaches 0. So this is the graph of the normal tidal expiration. Now, why I was discussing expiration and inspiration during spontaneous breath, because I want you to see the difference between spontaneous breath and a mechanical breath. And we'll try to compare the two. If you see here, the alveolar pressure drops. So half of this is inspiration, this is expiration. So if you see the alveolar pressure, it drops because of the drop in pleural pressure. Air flows in and the volume increases in the lungs. Opposite happens in expiration. This is a spontaneous breath. And this is brought up by we call P muscle, because the muscle diaphragm is mainly responsible. So it generates the pressure to bring out all these changes. Now, if you compare this with positive pressure breath, where your operator is not the muscle, which is the diaphragm, the operator for all this is your ventilator. So if you notice here, your pleural pressure is positive as opposed to being negative. Your alveolar pressure is positive as opposed to being negative. And if you notice here, your pressure at the end of inspiration, spontaneous inspiration, is zero. And here in positive pressure ventilation, at the peak of your inspiration, it is positive, which is your PIP. See the difference? It is a stark difference, or rather opposite to the normal pressures in the lung when we use the mechanical ventilation. Then your airflow, it moves in this direction, but here the airflow is pushed by the ventilator. This is the inspiratory flow, comes to zero. This is the expiratory flow. And you see the expiratory flow is positive because it moves out. Here the inspiratory flow is negative. And here your inspiratory volume, then your expiratory volume. So if you notice here, except for the volume, all three graphs are opposite to each other. That's very important to remember. So which means that during the tidal volume achieved during spontaneous ventilation is the consequence of decreased pressures, intraalveolar pressure, while the tidal volume achieved during mechanical ventilation is the consequence of increased intraalveolar pressure. So totally opposite to each other. So just the same thing, but I just want to give some numbers to it. So if you see the spontaneous breath, your delta P will be 0 minus 1. So that will create your positive pressure for the air to flow. Delta P, that means driving pressure. The air flows in. And at the end of the inspiration, the pressure is 0. So no air is flowing. The inspiration has ended. And then you have this expiration, then you have -1 here. So the air moves out of the lung. The delta P will be -1 in expiration. And then at end of expiration, it's all 0, no flow, which is your FRC. But this is the spontaneous breath. If you see the positive pressure, mechanical breath, this is your airway opening pressure, which corresponds to your atmospheric pressure, which is the ventilator pressure that we set, like positive inspiratory pressure. So if you see, we set, for example, a positive PIP of 20. So the driving pressure, your P always is 0, but you are driving this pressure. So your driving pressure is +20 as opposed to +1. And if you see end inspiration, the pressure was 0. And here your pressure is 20 at the peak of inspiration. And even though no air is flowing, but you are still at a pressure of 20. You don't lose the pressure until the expiratory valve opens and the expiration process starts passively. So you can very well see that there's a difference between a spontaneous breath and a mechanical breath. They are completely opposite to each other. So I'll just play a small video here. If you see here, this is how mechanical breaths are noticed when you use the ventilator. And think about it, which child or which unit will breathe like this? You can see clearly the chest is rising with each breath. So this is a positive pressure mechanical ventilation. And imagine a child who's on mechanical ventilator, he's getting a respiratory rate of 40, or in pediatric age group, maybe a little bit lesser. So with this 40, he's getting every hour such breaths which are 2,400, which are positive pressure breaths, which are harming the lung. Each breath is harmful. And in a day, the child is getting about almost 58,000 breaths. So I'll repeat this video, it's very brief. Just notice this kind of breathing is, in my opinion, abnormal breathing, but we are forced to use it because the child needs it. But consider these breaths have abnormal breaths. So please, when you ventilate the children, you make sure that you understand that you are using abnormal breaths, which are positive pressure breaths, which are completely opposite to spontaneous breaths. And each breath that you use is giving harm to the baby because it is opposite to the spontaneous ventilation. And this is the result. So this child, one of our children, or one of our neonates at birth, his child is intubated, and you can see the state of the lungs at birth. And at 48 hours, this lung is like this. So you can clearly see the lung is hyperinflated. The lung is probably somewhat emphysematous. You can see the chronic lung disease changes, and this is just 48 hours later. So this is what we do with mechanical ventilation. So with this one, I would like you to think, this is ventilator as our friend or our foe, foe as enemy. I personally consider mechanical ventilation as both. It's a foe if we don't use it. It's a friend when we use it. But even when we use it, it acts like a foe to us. So there is a saying that treachery of a friend is worse than the foe. So it's a treacherous friend. So even though it is a friend for you because it is helping you or your child or your patient in case when he needs it, but at least we should understand it's a treacherous friend. So in English, there is a famous saying that know your enemy. So when we say that it's a treacherous friend and it's an enemy for us, it's very, very important for us to know our enemy. And this whole course is actually designed towards this motto that know your enemy. Please consider mechanical ventilator as your enemy. So the more you know about your enemy, the more effectively you will try to protect your patient from the animosity of the machine or from the treacherous uh, skills or whatever is coming from your machine. So you have to protect your patient. So you can only protect if you know your machine the best. So we are at 9:32. So I'll take a small breather. We'll start after 2, 3 minutes our main topics of anatomy and physiology, and we'll try to be as clinical as positive as possible. So please take a couple of minutes of break, and if you want to drink water, but I suggest don't move away from your places. Otherwise, it takes time for you to come back and you'll miss. We'll start in a few minutes. I guess we'll start again. Welcome back. So we'll start with pulmonary anatomy and physiology, and as I said before, we'll try to be as clinical as possible so that it helps us in our practice. A very famous saying that all of us hear when we learn anything about pediatrics is that children are not small adults. They're different in their weights, ages, diseases, and everything. Uh, Similarly, when we practice neonatology, we realize that the neonates are not small children either. Uh, Also, if you extend this thought, the preterm neonates are not the same as term neonates. And even within preterm neonates, you have different weight groups. Now, there's a term used these days, it's called ridiculously low birth weight infants, which is about less than 400 grams, even less than 450 grams. Then you have neonates, which are extremely low birth weight. Then you have very low birth weight, and low birth weight, and you have term. So all these weight categories, based on their gestational ages, uh, poses uh, all these things pose different problems for you. So you have to learn uh, when you take care of different weights and age group in terms of gestational age. Uh, so it's not the same that you are when you're dealing with term babies, it's not the same as preterm. So in general, the pediatric anatomy, as we just mentioned, is not the same as adult anatomy, and we'll see that it's a disadvantage to the baby, and we will see a few examples of that. Physiology is not the same as adult physiology. For example, if you see the in neonates uh, at birth, even a term baby has 10% of the adult number of alveoli. So relatively speaking, they have lack of alveolar growth as opposed to adults. And this alveolar growth continues until age 7, 8 years, or some people believe that it continues until adolescence. So, but the point is that at birth, uh, their numbers is almost 10% of the adult numbers or the total surface area also. So that poses a problem with decreased gas exchange uh, as compared to adults, of course. Uh, transitional circulation, which is transiting from fetal to neonatal life. And there is the role of PDA, which closes, sometimes by 24 hours, sometimes there's a delayed closure. That poses a problem for us. Increased pulmonary vascular resistance in newborn. Similarly, now if you see pathology also is not the same. Uh, we see in pediatric age group, bronchiolitis, RDS, affected deficiency, meconium aspiration syndrome, persistent pulmonary hypertension, which is not the same as primary hypertension, or secondary hypertension, which you see in adults. And then you have the whole host of congenital malformations. More importantly, we deal with rather frequently diaphragmatic hernia, pulmonary hyperplasia, and other malformations. So all these things together, if you see here, the anatomy, the physiology, and pathology are not the same. This slide is showing you differences between neonates at birth and adults. I would just like to highlight a few things. If you see here, the lung compliance and the compliance of the chest wall are different. So the chest wall is more compliant, 5 times the adult, while the lung compliance is lower than the adult, which is 1/20th of the adult. This will repeat it in coming slides, and this is a very important subject that we will dwell more on this subject. Uh, Total pulmonary resistance is also higher, 10 times the adult, and oxygen consumption is almost double the consumption in terms of ml per kg per minute of the adults. Now we'll start with pulmonary anatomy, and I would like to ask few questions from all of us, and then that would make the outline of my today's session. The question is that do anatomical differences put a neonate at a disadvantage? Of course, the answer is yes. So we'll try to explore why. Why neonates go into respiratory failure early? Why neonatal lung are more prone to atelectasis? Why we must use external humidification for ventilated patients or the ones receiving supplemental oxygen? why we use straight blades in neonates for endotracheal intubation and not the curved blades. Curved blade technique is called Macintosh technique, and we'll see later on more details about it. And then the straight blade technique is called Miller technique. And there is a slight difference in the technique, but it's called Miller technique because the straight blade is called Miller blade and the curved blade is called Macintosh. So that's where the name comes from in the backdrop of I mean, when talk about techniques, this is where it comes from. What is Murphy's eye on the ET tube? What is the role of it? And why inspiratory and expiratory striders have different etiologies? So we'll try to explore or answer these questions at the end. I will try to, give a summary of all this. So just keep these questions in mind as we go along, learning from our slides. We will get the answers to all these questions. And I hope you appreciate that all of them are very relevant questions when you look at the pulmonary anatomy. And these are all the questions which will be answered in coming slides in relation to the anatomy. We have not yet gone to the physiology part. Okay, if you see the pulmonary growth from fetal to adult life, notice here this is the 30 weeks gestation, a term baby, adult life. Importantly, if you see here, the surface area increases by 23 folds from a term to adult life. So, and of course, if the child is, or if the neonate is more preterm, the surface area is even lesser. So as you go towards more prematurity like 26, 24, 25, 22 weeks, you can see the surface area is very, very small. And then there's a surge of surface area after the 30 weeks gestation. You can see it's a flat line here, and then the line goes steeply, very high in this area because your surface area increases. So you can see from 0.3 meters square to 4 meters square. So that's a big jump. So, and if you have a baby which is less than 30 weeks, of course, you are somewhere here. Number and diameter of the alveoli continue to increase after birth. By 8 years, we have about 500 million alveoli. At term, we have about 5 to 50, and depending on the gestational age, sometimes we don't even have alveoli present, as we'll see in the next slide. Uh, at the same time, the alveolar capillary surface area increases by 20 folds from birth to adulthood. So it's not only the alveolar growth is happening, alveolar capillary growth continues as we go from preterm to term to adult life, even after birth. From birth to adult life, there's a 24 increase in the surface area. And it matches the growth of the alveoli postnatally, which is, of course, important because the gas exchange surface area comprises of alveolar surface area and the capillary surface area. If you notice here, these are the stages of fetal lung growth, and this is the term, and we have the lung growth continues after. You can see here even the microvasculature maturation, alveolar growth continues. Then by 24 weeks, you have surfactant production starts. But by 34 weeks, your surfactant pool is very small, 3 to 4 milligrams per kg. And by term, you have 100 milligrams per kg of the surfactant pool. And after that, there's a small dip of over next 3 months, but it is not clinically relevant. And then your surfactant production on a daily basis continues with a plateau. So this is important that as we go um, uh, from 24 weeks to the term, our surfactant production increases rather rapidly. But notice one thing that below 24 weeks, there's no surfactant production, uh, even not even in this small amount. So the message here is that if we can coordinate with our obstetric colleagues and try to make sure that we work together with them to extend the fetal life as long as possible when there's imminent preterm delivery. So they have different ways they can delay the preterm delivery or premature birth. Uh, the longer, the better. Even a day makes a difference. As you can see, the surfactant production increases, and of course, the lung growth and maturation continues. If you see the alveolar growth, sorry, the airway growth, starting from zero generation, it goes to 23 generation by term. And after that, there is no further generations. So the airway is complete by the term gestation, but the alveolar growth and the capillary growth continues beyond until 6, 7 years of age. And you can very well see here that we are talking about the growth in terms of capillaries, alveoli, and airways. And the relevance of this is that any injury to the lung involves damage to the airway alveolo-capillary unit, which means your airways will be affected. So you have, like in chronic lung disease or BPD, frequently you see patients going into bronchospasm. Sometimes they need bronchodilators. I'm talking about CLD patients. Of course, there is alveolar damage. You have septations, which are damaged, and there is simplification of the alveolization. And then your pulmonary vasculature, microvasculature is damaged too. And very commonly, even early in the course of chronic lung disease, before it turns into bronchopulmonary dysplasia, your microvasculature is damaged, and it is manifested as pulmonary hypertension in those units. It's very early in the course of chronic lung disease. Another important point is when you're counseling the family, then you have to tell them that any injury, and remember, as we said, the lung injury that we are talking here about is the mechanical ventilation that we use, and some other, of course, other injurious things are happening when they are growing in the incubator rather than being in utero. So the injury during development phase is more serious. We have to let the parents know. But the silver lining is that because the prematurity or even after birth, the growth continues. So the potential for recovery is enormous. So even though the injury leads to severe consequences, but then there's a big potential for recovery. And the injury is more serious because it hampers the development. But even though it hampers the development continues, and the child recovers, most of them at least, from PPD. They do have some issues with their lungs, but they can get off the oxygen as they grow into their lives over a few months to a year. What are the factors affecting fetal lung growth or maturation? Very important is of course, intrathoracic space. And we see this when we see patient with congenital diaphragmatic hernia, where the intestines occupy the space and limit the lung growth. Hydrops fetalis, when you have pleural effusion, if there's an external pressure on the lungs, there is hampering of the lung growth. Skeletal dysplasias, where you have thoracic wall is affected, then the lung has limited space to grow. Other thing, other factor which is important is a fetal breathing movement, uh, which stimulate the lung growth, possibly by stretching the pulmonary tissue. Fetal lung fluid is very important. This fluid is produced by the lung itself, and it is excreted from the lung into the amniotic space, contributing to the amniotic fluid. So the adequate amount of amniotic fluid is also very important. And we have seen time and again oligohydramnios retarding lung growth, like Porter's sequence. Then endogenous steroids are important. You have a mother who has choriamnionitis. It puts a stress on the fetus, and the fetal steroids are increased, and it matures the lung. Actually, it's a positive influence. Is the only minor benefit of mothers having choriamnionitis is that the lungs are relatively more mature because of the steroids release, because of the stress of infection. Then your maternal diabetes uh, inhibits lung maturation, and you have seen rather commonly that infant of diabetic mother at 36, 37 weeks, they sometimes require positive pressure ventilation and supplemental oxygen, sometimes surfactant, and because the lung growth or lung maturation rather is inhibited, and they present with RDS or surfactant deficiency. Now, role of antenatal corticosteroids. Of course, this is a topic that is very close to our heart, but uh, this is done by our obstetric colleagues, but it makes a lot of difference in our practice. Basically, these steroids given to the mother when there's an imminent preterm delivery They increase the fetal surfactant production uh, by accelerating the development of type 1 and type 2 pneumocystis. So it needs time for these steroids to work. If the mother receives the steroid like half an hour, 1 hour before delivery, it is not very beneficial. Betamethasone and dexamethasone are commonly used steroids. Now, I have a clinical scenario that I would like you to think about. A mother arrives to emergency department and delivers a preterm baby. She doesn't know the gestational age, but when you see the baby, you estimate that this baby is around 26 weaker. The mother was on prednisolone 10 milligrams daily for last 7 days for her asthma. Baby goes on to mechanical ventilator with moderate support with FiO2 of 40%. In the morning rounds, your colleague asked you if antenatal corticosteroids were given to the mother prior to delivery. Your answer is, you can answer yourself. I know you are muted, but I will see. The answer, if your colleague gives the answer, that's yes, the steroids are given because she was on prednisolone, even though there was no time to give dexa or beta methasone, which is the commonly used one. But it doesn't matter. She's on prednisolone for last 7 days. So yes, she has received antenatal corticosteroids. So the answer to this one is the answer should come as no. The reason being that hydrocortisone, prednisone, and prednisolone, they are susceptible to inactivation by placental enzyme. So the active form of these steroids do not reach the fetal circulation. Maybe very little, 10% or 15% reach to the fetal circulation because these steroids are inactivated by the placental enzyme. So what are we left with is only betamethasone and dexamethasone because they both cross the placenta in their active form because this enzyme which inactivates these steroids, it does not do for betamethasone or dexamethasone. So when you are dealing with a mother who's taking any steroid other than betamethasone or dexamethasone, she's considered as if there is no antenatal steroids on board for the fetus or for the baby that you're dealing with. The other aspect of this is that these steroids, and this is of course for obstetricians, but if they ever ask you for your input, you can tell them that these steroids are very safe during pregnancy because they don't cross the placenta in active form and does not affect the fetus. So from the fetal standpoint, any chronic use of these steroids is safe, but at the same time, it does not give any benefit to the fetal lung maturation. Only these steroids are to be depended on. And then, if mother has received these ones, you consider that mother has received antenatal steroids or else no. Chest wall rib cage. This is the difference between the neonatal rib cage and adult rib cage. The difference is that the infants or neonatal ribs are elevated and they are more horizontal. If you can see here, they're not as oblique as this one, they're more horizontal with shorter course of intercostal muscles as compared to adults. So what is the consequence of this? The elevated ribs, it produces lesser increase in intrathoracic volume with diaphragmatic contraction. So when the diaphragm contracts, because of this anatomy, as compared to adults, there is lesser increase in intrathoracic volume. And of course, as we saw before, intrathoracic volume is mandatory for effective inspiration. Also, the rib cage is soft because of less ossification and intercostal muscle tone is less. And that is why the rib cage or the chest wall is very compliant. And we'll talk more about it. This compliant chest wall or soft rib cage is beneficial in its passage through birth canal, helps the delivery, and for future lung growth. But at the same time, it's a big disadvantage when the lungs are diseased, as we see in the future slide, in the coming slide. So you start from here. So the respiratory system is made up of chest wall with lungs. Now, remember that both chest wall and lungs are elastic tissues. What do we mean by elasticity? So when we say the chest wall is elastic, there's a tendency for the chest wall to recoil outward. But on the other hand, the lung elasticity demands that there is a tendency to recoil inward. So please, uh, I want to highlight this difference and make sure that you understand this, that the chest wall elasticity demands that the chest will recoil outward and the lung elasticity will demand that the chest will recoil inward. They're opposite. So if you see the elasticity or elastance formula, is it opposite to compliance? So elasticity is the property of any object, in our case, chest wall and lungs, is the property of the object to return back to its original position after having been stretched. And stretching is the compliance. So after the lungs or the chest wall has been stretched, the easiness that these objects or these uh, chest wall and lungs will go back to original position is determined by the elasticity or the elastance. So remember, elastance is opposite to compliance. So remember, we said our chest wall is more compliant than adults. So what will 3 to 5 times the adult value? So what will happen? That the elastance will be lesser. And lesser elastance means that the ability to spring outward or to recoil outward will be lesser. So it's just a double negative thing here. So there is a tendency to go outward, and this tendency is lesser because of the increased compliance of the chest wall, as opposed to the lungs. The lungs' tendency to recoil inward, if you see again, it is opposite to the compliance, but the lungs are less compliant. So if the lungs are less compliant, the elasticity will be more. So which means the tendency to recoil inward will be more. So that the low compliance of the lung will ensure that the elasticity is more, which means that the tendency to recoil inward will be more because of decreased compliance. Compliance and elasticity are opposite to each other. What is the result when there is increased tendency to recoil inward? Tendency of the lung to collapse. And we'll come back to this. And what happens here? What are the consequences of decreased tendency to spring outward? Is that your intrathoracic pressure or your pleural pressure is lesser. Again, we are talking about relative terms. Is lesser. So your negative pleural pressure, which is required to generate your inspiration and your tidal volume, is lesser as compared to older children or adults because of this phenomenon. And what are the consequences of this one? That under normal circumstances, to move a similar tidal volume, you need more work of breathing. So a neonate work of breathing is inherently, even with a healthy lung, with healthy airways, is inherently more as compared to older children or adults because of one factor, that the chest wall is more compliant. More compliant means less elastic. Less elastic means tendency to recoil outward is less. Intrathoracic pressure is lesser comparatively. The generation of tidal volume is difficult, so more work of breathing is required. At the same time, when the lungs are diseased, the neonate has difficulty to increase the tidal volume when the lung has any pathology. So already, comparatively, relatively speaking, the neonates are at a disadvantage to generate volume, tidal volume, because of the lesser pleural pressure or lesser intrathoracic pressure. But during the disease state, this ability is even further enhanced, or lack of ability is further evident, and they cannot enhance their tidal volume effectively. And that is why you notice that the newborns, they rely more on tachypnea rather than increasing the tidal volume. So if you want to increase your mechanical minute ventilation, there's only two ways. You either have tachypnea or you increase your tidal volume. And we'll see later on this. So they cannot increase their tidal volume effectively. So they basically rely more on tachypnea. So that's why the neonate becomes tachypnic very early, and it's an early sign of respiratory distress. And we should take all tachypnic infants very seriously. And this is the reason why they become tachypnic, because they cannot increase their tidal volume effectively. The other consequence of this is that for the lung, again, relatively speaking, for the lung, it's difficult to maintain the FRC to prevent end expiratory lung collapse. And this is the and the neonate will use different mechanisms to generate PEEP, which is called expiratory braking. We'll see later on. Then the result of this one is the lung will try to collapse. So here you see the tendency of the lung to collapse. Here is the tendency of the lung to collapse. So collapsing forces are dominant as opposed to the outward recoil of the chest. So because the collapsing forces are dominant, that's why there's a tendency towards atelectasis. And you have seen frequently in our clinical practice that there's post-extubation atelectasis, uh, surfactant deficiency, even mild deficiency will cause severe atelectasis because there is inherently the tendency for the lungs to collapse. And this phenomena, which I just explained, is responsible for this. Clinically, how we see this? Okay. We see this, the compliant chest wall is evident when we see the substernal retractions, as you can see in these two units. It's actually sign of underlying diffuse atelectasis, as we just mentioned. And our main disease that we deal with is RDS. And you can see that this is a very common sight for us to see those children who are not intubated to breathe like this with substernal retraction. And this is the reason for this is compliant chest wall and underlying diffuse atelectasis. And you can see sometimes you will see this also. Uh, this also has a compliant chest wall, but here you can see the child looks really happy. This condition is called pectus excavatum, and the lungs are healthy, and you have to differentiate and tell the mother that as the lung compliance improves, when the ribs are more ossified, this pectus or the retractions at the substernal level will disappear, will go away. Now coming to diaphragm. Diaphragm is relatively flatter and as opposed to more domed in adult, and also it's inserted into the chest wall with a larger angle. And what are the consequences of these two factors? That the downward displacement during contraction, when the diaphragm flattens, because it's already flatter comparatively, of course, or relatively speaking, it's already flatter, so the increase in thoracic volume is lesser during inspiration. And also there is a posterior limb distortion happens because of this posterior limb of the diaphragm. And when we see subcostal retractions, we know indirectly that the diaphragm is functioning hard. And you can see this is a child with subcostal retraction. This one is more severe. And this is because there is a posterior limb attached to the ribs, lower part of the ribs. And when the diaphragm contracts harder, you see subcostal retraction. So your subcostal retraction is telling you that your diaphragm is functioning more than its uh, usual function or usual capacity. And at one point, the diaphragm, when the child goes from here to here, he will sooner than later go into respiratory arrest because the diaphragm cannot function any longer because it goes into fatigue easily. And why does it go into fatigue easily? There are two types of muscle fibers in the diaphragm and intercostal muscles, type 1 and type 2. The type 1 fibers are fatigue resistant, and the type 2 are the usual ones. So if you see in this bar graph, the preterm infants, this is for the intercostal muscle, this is for the diaphragm. So this is the type 1 fiber, which is fatigue resistant. So you can see the type 1 fibers, the number of fibers increase over increasing gestational age and with number of years after the birth. So if you have a preterm baby as compared to even a 2-year-old child or a term child has lesser type 1 muscle fibers which are fatigue resistant. So what is the consequence of this is the diaphragm being the main breathing muscle, diaphragmatic fatigue happens early, and it's a main reason for respiratory arrest in infants with pulmonary pathology. So try to remember this, the diaphragmatic fatigue is a real phenomena. And when the child goes into deep subcostal retraction, don't leave the child breathing like this, even though he may be saturating well. You have to offload his diaphragm. Otherwise, the diaphragm will go into fatigue and you will soon have a child with respiratory arrest. Now, this X-ray shows Sorry. This is the diaphragm, this is the lung, and this is the liver. And these are the intestine. This is condition called eventration of diaphragm. It could be congenital when the diaphragm muscle is not developed and it is replaced by fibroelastic tissue. Could be acquired, but from birth because of the injury to the phrenic nerve. It could be either traumatic birth or thoracic surgery, usually done for congenital heart disease. And if there's a damage to the phrenic nerve, the diaphragm is paralyzed. And after that, diaphragm goes into muscle atrophy and replaced by fibroelastic tissue. And you can have a similar situation where the diaphragm can be eventration. Now, this is a severe form of eventration. Usually, the eventration is not that severe. Uh, if it is up to one or two ribs higher, uh, the children can live effectively, that it doesn't make any difference. But because this is a severe condition, and the diaphragm, because of its weak status, has been displaced into the thorax, the breathing is compromised because you can see the liver is pushing the diaphragm into the lungs. And these children sometimes require oxygen, they're tachypneic, they cannot feed, and they require surgery, which is the diaphragmatic plication. And this child underwent the diaphragmatic plication, and this is his post-operative uh, X-ray. Okay. Accessory muscles of respiration, which are internal intercostal muscles, sternocleidomastoid muscle, trapezius, and you see intercostal retractions because of the work of these muscles. Rather than subcostal, you will see this also. Subcostal retractions will be before you can see this. So if you see these kind of retractions, you know the diaphragm is already working to its maximum capacity, and now accessory muscles have gone into action. This is the child more severe retractions. Again, you have child with substernal retractions and subcostal retractions. And here, because of the sternocleidomastoid muscle, some condition called tracheal tug, it is usually a sign of upper airway obstruction. But this one is lung pathology, all these three pictures. We are past 10 o'clock. So I would like to stop here, trying to be, sensitive about the time. I know you guys are busy. We'll stop here and we'll start from here in the next lecture.